You're all good. We did it. Well done. You are muted, so you might need to unmute yourself. That's the only IT issue that I can't help you with. And our lovely Nisha has started the recording. And I'll hand over to you.
Am I speaking now?
You are speaking beautifully.
Fantastic. Super duper. Well, thank you so much for asking me to come along. I think I've probably got too many slides, so I may whip through some of them. If I can't monitor a chat, so if Chandi, if you can monitor it, and feel free to stop me at any time, because a conversation is always better, you know, if there's more than one person in it. So thank you for asking me. I'm going to talk a little bit. Some of it's quite basic, some of it's less basic. So just start at the beginning, assuming that no one knows anything about kidneys or CKD or whatever. So how are we going to detect and manage CKD better in primary care? So learning objectives, what is CKD, who's at risk, what is the extent of the problem, what health risks does it represent, how can we manage it better in southwest London? So we here are our kidneys. What do? Well, most people have two kidneys, not all. They sit in the lower back. And most people, in fact, when you tell them you've got chronic kidney disease, they say, oh, should I stop drinking alcohol, doctor? So there's a very poor general knowledge about kidneys and what they do. They make urine, of course. That is their number one job, which is soluble waste products, usually made soluble by the liver, by its metabolism of waste products, making them soluble and excreted in the kidneys. They filter your blood all day, every day. They take about 25% of the cardiac output. So if you have heart failure, very, very often you'll have chronic kidney disease as well because of poor blood flow to the kidneys. So cardiorenal disease is increasingly recognized, as I'm sure you know, and I'll just touch a little bit on cardiorenal disease. So they are the hardest working organs in your body. And not only do they produce wee in a greedy fashion, they produce hormones, say they produce red blood cells, or they help with the maturation of red blood cells, and they are responsible for the final step in producing vitamin D. So patients with kidney failure are often anemic, and their hemoglobins will drop to about 6 if unsupported with exogenous EPO products. And very often our patients are vitamin D deficient. So they do quite a lot, them little kidneys do. What is chronic kidney disease? So it's not a one-off blood test saying that you've got an abnormal EGFR. Chronic kidney disease is a term used by doctors or any healthcare workers to include abnormality of the kidneys, even if there's only slight damage. Chronic to patients often means terrible, awful. Oh, it's a chronic condition, doctor. It's awful. But of course, we know that it doesn't mean that. It just means it occurs over time and doesn't get better. So it's not acute, it's chronic. So chronic kidney disease usually involves the kidneys shrinking away for whatever reason. Either the blood supply is poor or there's primary kidney disease. And there's often, importantly, no signs or symptoms. I often see patients present at stage 5 CKD, and I'll go into that a bit later, who have absolutely no symptoms whatsoever. Usually when a patient is approaching end-stage kidney disease, they will become nauseated and have lack of appetite and fatigue, and that's usually the extent of the presenting symptoms. So how do we test for CKD? And this probably is the most important thing that we do. And this is kind of aimed at patients, this slide. So we can do blood tests. That's the EGFR. And we need 2 measurements of EGFR to diagnose CKD. And there needs to be an interval of 3 months. So you can't diagnose it on one blood test. There has to be a 3-month interval. So if somebody's got abnormal kidney function, we can't say whether it's acute or chronic. If we think it might be acute, we should recheck that EGFR within a few weeks. If there's no change, no improvement, whatever, then we need another test at 3 months to say it's chronic. So you can have a normal EGFR and an abnormal ACR and still have chronic kidney disease. You can have a normal EGFR, a normal ACR, but you can have a structural abnormality of your kidneys, and we still label that CKD. So coding's really important, and we do try to code it according to EGFR and ACR. I quite like this little bit here because I use it quite a lot. I found it on the NKF, which is the National Kidney Federation. That's the American website, to explain to them it's not a percentage, the EGFR. Below 60, you're starting to get into chronic kidney disease territory that they can understand. And I will say you're here. And when it gets to 15, you've got advanced CKD 5 kidney failure. Although we don't like using the word failure, do we? So along with your EGFR, we have to talk about albuminuria. So and albuminuria, severe, is over 30. Microalbuminuria is between 3 and 30. And no albuminuria is when it's normal or your ACR is less than 3. Simple. A1, 2, and 3. And here's the heat map. This is the bit that I think is vital to understand this, actually. So here's our stages of, can you see my mouse moving, Chandy? Can you
Yes,
see
we can.
Yeah, fantastic. So, really, we start talking about CKD when the EGFR is less than 60 in reality. So that's G2, and we go and stage 5 is when the EGFR is less than 15. Stage 4, 15 to 30. Stage 3 is really the biggest because it's sort of 45 to 60 really, or sorry, 30 to 60. 30 to 60. So that's where the majority of our patients will lie in this. So if we just focus on the CKD stage 3, and then you've got your degree of albuminuria, you can see that somebody that has only mild or early CKD 3, but who has no albuminuria, microalbuminuria, and established albuminuria with an ACR of only 30 has a very, very high risk of progression. So this changes your risk from being quite mild risk of progressive CKD to really very serious risk of CKD. And that's just in this very mild CKD according to EGFR category. So you can see how important this multiplier is of having a raised ACR. So what we're doing is, and I'm trying to do it in all of my secondary care letters and say this patient has CKD G3 A3, and then I write high risk. High risk of what? Okay, not on this slide, but high risk of progressing CKD, high risk of all-cause mortality, high risk of cardiovascular event, high risk of cardiovascular mortality. So all the bad things, really. So yeah, that is very, very, very important, that heat map for me. So who is at risk for CKD? Well, you know this. So it's obviously people with diabetes and high blood pressure, and that makes up more than half of CKD in our primary care community. If you add in anyone with a cardiovascular event or obesity, family history, tobacco use, and anyone over the age of 60, you're talking about a huge chunk of our population, aren't you? And these are accounting for well over 2/3, probably as close as 80% of CKD that we're seeing in primary care, with only 20% of CKD being attributable to genetic kidney disease and primary autoimmune or vasculitic glomerulonephritis type diseases. So we need to start thinking about all these patients as they truck in through our doors. Let me just, sorry, I'm not going to go through that one because that's not projecting well, sadly. I'll go on to the next slide. Okay, so what is the scale of the problem? So if we look globally, and this is a slide I do love to show, we know that these are the leading causes globally of death, right? Cancer and cardiovascular disease. So the vast majority of deaths across the world is cardiovascular disease. And then comes respiratory disease, diabetes, dementia, all the rest. But kidney disease is here at number 12. Now, even as little as 5 to 10 years ago, this did not feature on this graph. So there's either massively increasing prevalence, or what's more likely, increasing awareness that actually chronic kidney disease leads to a massive risk of death, as I said to you, cardiovascular events, cardiovascular mortality, septic deaths, all-cause mortality. And it's likely that in the next 10 years that this will be in the top 5. Risk factors for any death or disability. This is males, this is females. They're all the same. It's all cardiovascular risks. So child malnutrition, high blood pressure, air pollution, high fasting glucose, high BMI. For women, tobacco, high blood pressure. Look, it's all the same, isn't it? It's all these risk factors that we know about that we really do need to start tackling in primary care. So in Southwest, that's globally. What about Southwest London? So in Southwest London, or just in London alone, sorry, there's 300,000 patients with chronic kidney disease. In London and Surrey, we provide a lot of care for hemodialysis patients. There's around 15,000 patients on dialysis or transplant in Southwest London and Surrey alone. And the cost of this is going up and up and up. And it's expected that the cost or the bill for dialysis and kidney transplantation will quadruple in the next 10 years. So what we have to do is, of course, stop people developing end-stage kidney disease, because I can tell you from where I look, it's a bloody miserable way to live your life. So so this goes on about the cost, masses, premature deaths, billions of pounds that the NHS spends on dialysis. The hospitalizations are enormous. You come into my ward, you see people there for 3 months, even 6 months, because of their really terrible comorbidities, chronic conditions, dialysis dependence. But of course, the cost is not what we're really focused on. We're talking about the harm. So this is quite a, this slide illustrates that only the lucky ones with CKD will develop end-stage kidney failures. The rest will die from a cardiovascular death or an infection well before they develop end-stage kidney disease. This is a horrific slide. The first bit of it will show you that this is cardiovascular mortality, so dying from a heart attack or a stroke in the general population. And you can see that, you know, when you're young, your risk of dying from a heart attack or a stroke is pretty low. And that really starts happening when you get to around 65 or so, and goes up with age. But if you are on dialysis, your risk of dying, even if you're 25, is as high as an 85-year-old in the general population. This is light years away from normality, right? Just to they have calcification, terrible cardiovascular risk. It's a scale that is just totally different from the general population. I'm going to skip that one. Now this is a builder. They don't build well on this, do they? I'll just keep going through until it goes. Not changing, is it?
Keep clicking, maybe. Should go through.
Ah, there we go. Okay, so I've actually already described this. So with your decreasing GFR and your increasing albuminuria, you've got an increased risk of all-cause mortality, cardiovascular mortality, end-stage kidney disease, AKI, and progressive CKD. Not good. So coming back to what we're going to do, a single EGFR and ACR do not determine the risk in isolation. So if we think it's an AKI, we check within 2 weeks. If we think it's then not an AKI and likely CKD, we check it in the next 3 months, once or twice, or even up to 3 times. What is progressive CKD, right? So if there's a fall in GFR of 25% in a year, or a fall in eGFR, this is nice guidance, of more than 15 mils per minute per year, then you've got progressive CKD, and we want to see those in the kidney service, or we want to try and do something about that risk. I would say personally, a fall in eGFR of 20% in a year, or a fall in eGFR of more than 10 mils per minute per year, is actually really quite a staggering progression, because if you're losing 10 mils per minute per year, and that's a poorly controlled diabetic, by the way, if you've got a GFR of 40, it's 4 years before you're on dialysis. If you've got a GFR of 40 and we cut their progression, it can be 10, 15 years before they require dialysis.
I've got a question, Pauline.
Go on.
Can I quickly just stop you? So when we're doing the EGFR side, if it goes back up to above 60 and then comes back down afterwards, down to there. So it's kind of one of those ones that's going up and down, but it's not too consistent readings.
Yeah.
Would we classify that as CKD 3, if call it, if it was below 60?
Yeah.
Would we classify that, or would we not?
Yeah, you would classify it, but so you have to. It's a really interesting question. So you have to code it, don't you? And that's the important thing about putting in the CKD 1 to 1, the G 1 to 5 and A 1 to 3. It will change, and actually the thing that makes it change the most is people that are on diuretics. So your cardiorenal patient will change all the time. So do you need to keep recoding it? Probably not. Probably draw an average through your eGFRs and your ACRs, because we know they change, and just code it as to what the average is. And that's what I find myself doing. I trend out the eGFR and I look then to see what's the average progression over the last 5 years, because it's really important how quickly they're progressing. So refer to renal if they've got progressive CKD, if they've got blood and protein in the urine of genetic disease, or stages 4 and 5. And I think that's fair enough, unless the stages 4 and 5 are, somebody that's not really going to benefit from interventions as such. So this is also quite important, and we know that it's a progressive disease that leads to poor outcomes, and people with type 2 diabetes and hypertension are those at the greatest risk. I'm going to add in obesity to that as well, because obesity kind of contributes massively to the type 2 diabetes and hypertension, and the more the worse obesity becomes, the worse that these two become. So then you get your cardiorenal damage and all the rest of it, and this just shows you the cycle of what we're actually looking after in the community. We're not just looking after patients with CKD, are we? I mean, we're not. We're looking after patients with type 2 diabetes, with heart failure, and with CKD. And actually, each leads to the other, as it were. So the more hypertensive you are, the more likely you are to have heart failure. Your heart failure gets worse, your CKD gets worse. And so we have to treat as a continuum. And I will say that we are looking now in the next month or two to set up a cardiorenal metabolic clinic, which will look after patients with cardiorenal metabolic disease in one place, with cardiologists, nephrologists, and diabetologists, and hopefully we can make the management of these patients better from one point. So what are we going to do to improve outcomes in CKD, the renal outcomes and the cardiovascular outcomes, because we have to think about these together? Well, number 1, 2, and 3 is blood pressure control. We need to try and reduce albuminuria and control blood glucose and blood lipids. And in order to do that, we actually do need to think about specific medications that we have to hand. So our ACE/ARBs for blood pressure and albuminuria, then our SGLT2 inhibitors, our mineralocorticoid receptor antagonists, and our GLP-1 agonists. And I'm hoping that with our cardiorenal clinic, we can get patients on all of these things sort of fairly in a fairly standard fashion. So this is possibly important to you. It might be if you could put that website onto the chat, that would be great, Chandy, because this is our local guidance for Southwest London, written in collaboration with myself and Richard Hull, one of the nephrologists at George's, and with many of our primary care colleagues, and this will sort of take you through what our algorithm of managing CKD is in Southwest London. I would recommend that you try and access that site and have a look through it. This is kind of how we do it, what we do and how we do it. And so just cutting into that, that's what I've told you before. This is really important, that we screen patients at risk. That's our diabetics, our hypertensives, anyone who's got a cardiovascular history, anyone who's got a multi-system disease, etc., etc., etc. We screen them. We do their a kidney health check. We do their GFR and their ACR, and we should be doing those together, right? So a kidney health check is an eGFR, an ACR, and a blood pressure check. And then we code them. So onto their code goes G3A2 or whatever their code is. And then we have to talk to that patient and tell them that that's what they've got. And that's challenging, given that we're going to be screening, coding, and then talking to all of these patients.
Can I just quickly just add in one part, which I know is a question that's come through, but it's confusing, just on that slide. As you'll see from everyone looking, if the person has got a positive ACR above 60, they do not have CKD. So do not code G11. There isn't a G11 effectively on that front. So you want to be making sure it's where they've got the positive albuminuria, we would be coding that as G1A2 or A3, G2A2, A3, unless that's indicated elsewhere from a nephrology letter or structural abnormality or anything else. I know that's a question that's come through, so I thought I'd just point it out because it was on the slide.
Really important. Yeah, if they've not got CKD, don't code them as such.
Absolutely. Sorry to interrupt. I know it's a question that's come through, so I thought it would make it easier just to add into it.
No, I'm delighted that you interrupt. So here's a patient with high blood pressure, CKD label. Nobody's told the patient, of course. There's no blood on the dipstick. They're on a candesartan and amlodipine, and their blood pressure seems to be quite well controlled. But if you look at this, the eGFR is coming down. It doesn't project terribly well, but the GFR has come down from 40 down to 30, or 45 down to 30. So that's at least 15 mils per minute over the course of a year or so. 10 years. So they've got progressive CKD and they've got albuminuria. So they are, GFR there is 20. So it looks like they're CKD G4A3, right? G4A3 really in the red. Oh, in the red there, massively high risk of progressing. He's 52. He's going to be on dialysis quite soon if we don't do something about it. And yet, it's just been monitored for years and years and years, and this is part of the problem that we see. This patient is 75. He's a diabetic. He had a previous AKI. He's also been labeled with CKD, although not coded as such. He's on a whole ton of medication. His blood pressure is not well controlled. His HbA1c is sub-ideal. His GFR is 30 and his ACR is high. So he is on the heat map where team. His GFR is 31, so he just sneaks into this category here, although he's borderline between 29 and 30, so he's at least 3B plus, and he's got massive ACR, so he's massively at risk of progressing, isn't he? And this is where this horrible kidney risk failure equation comes in. Now, I don't personally use it very much. I am not. You can use it if you can find it. Again, if you could put Chandy this risk failure calculator into the chat, that would be helpful. But this will tell you what their risk is of developing end-stage kidney failure over 5 years. But actually, if you use this heat map, it pretty much tells you what their risk is of progression, not at 5 years and not with a number on it. But I find very few of my colleagues using this, and some do, some don't. It's not really been terribly widely adopted. I would much rather that you code it and don't get too involved with the kidney risk failure. So when we look at patients 1 and 2 and we calculate their 5-year risk, they've got high risk. About 1 in 3 of them will develop end-stage kidney failure within 5 years, and that's pretty damning. So what is optimized CKD management? So if the GFR is below 60 and or they've got albuminuria and significant risk, then they have significant risk factors for cardiovascular disease and for progression of CKD. We need to agree a management plan with the patients. Number one, and nobody gets out of my office, if they smoke, I will spend the whole consultation saying, you really need to stop smoking. Your risk of having a cardiovascular event is huge. So if they smoke and they've got high cholesterol, they will have a cardiovascular event if they've got CKD. So that for me is number one. Health, exercise, low salt diet, all the rest of it. Obviously, nephrotoxic drugs should be looked at, but not necessarily stopped. I would usually stop the non-steroidals. The lithium, I've had a few patients, right, really do badly when I've stopped lithium or substituted it. So that risk has to be with benefit. Same with sulfasalazine. So definitely stop the non-steroidals, but I would other disease modifying drugs are just as important. Vaccinate. Tell them about the risk of AKI, control the blood pressure, and manage cardiovascular risks. By that, I mean cholesterol and smoking. Okie dokie. Blood pressure management. I hate this slide. I'd like to delete it because ignore all these targets. They're pretty much. Shandy, I can see you nodding furiously. Right. The Europeans and the Americans say if you've got CKD, your blood pressure target should be 130/80. We've got some really complicated advice as to whether your ACR is 70, less than 70, whether you've got diabetes, not diabetes. Just if I could cross those out, I would love to, and say this is roughly where we should be ballpark aiming, 130/80, okay? For all patients, atorvastatin 20. That's anyone who has a CKD code should be on atorvastatin 20. And there's been some practices recently, I know, doing audits and saying, oh, I'm just looking at all my CKD patients, should they be on a statin? And my advice and guidance is always the same, yes, please, unless they've got a contraindication, just put them on a statin, atorvastatin 20. Don't worry about dose incrementing, leave that to whoever is really looking at them in depth, but please start atorvastatin 20.
Questions come in. Does that still include patients who are potentially on dialysis?
Yep.
Okay, perfect. Thank you.
I'm going to, okay, so let's look at this patient. This was our 75-year-old man. If you can recall him, he's diabetic, he's had an AKI, he's been staged, if you like. He's got G3B plus, A3, massive risk of progression. He's on amlodipine, atenolol, a thiazide. He's on all the right stuff. He's on atorvastatin 10. Probably that should go up. He's on metformin and linagliptin, and his blood pressure is not well controlled. So what are we going to do next, team? He's high risk. Please refer. That's probably the first thing. Review his lifestyle. Make sure he doesn't smoke. Review his medication. Increase his statin to 20. Increase his ramipril to 5. And improve his blood pressure. And what are we going to do next? I hear you all shout.
I've got people shouting DAPA for CKD
DAPA.
in the background.
Exactly. Well, we've got DAPA and EMPA now. Okay,
we do.
It's not on the formulary yet, but it should be. So it's had a license.
It's coming.
So it's DAPA and EMPA for CKD. So mode of action. Do we want to go into mode of action? I don't know. So where the ACE inhibitors work here to reduce the intraglomerular pressure, the SGLT2 inhibitors work here, and they block the sodium and glucose co-transporter protein, and that's really interesting. So what you do then is produce sugary whey. So you block the channel that makes the kidney reabsorb salt and sugar. which really I find so fascinating, because when you think about a diabetic patient, they're running high blood glucose levels the whole time, and their SGLT2 channel is working away to the dozen, reabsorbing all that glucose, but it's also reabsorbing all that sodium. And so when you see a diabetic patient and they're all boggy and they've got resistant hypertension, that's because their SGLT2 little channel is reabsorbing the sodium and the glucose. So what we want them to do is to pee out the sodium and the glucose. And the sodium is every bit as important as the glucose. And it kind of gets forgotten about unless you're a sodium enthusiast like myself. So you pee out salty, sugary urine, and that lowers intraglomerular pressure. Bingo. What do we know about the SGLT2 inhibitors? So we know that every new diabetic drug has to have a cardiovascular safety trial. So patients at risk of cardiovascular disease all had to be given these new drugs when they were coming to market. So empagliflozin, canagliflozin, and dapagliflozin were all tested early on, like 15 years ago. We're talking here, and yes, they were shown to be cardiovascularly safe. In fact, they prevented cardiovascular disease. Well, that was interesting. We haven't seen that before with a diabetic drug, have we? We haven't seen that with sulfonylureas. We haven't seen that. Metformin's too old, so we don't know if that does or doesn't improve cardiovascular mortality, but quite possibly it does. But it doesn't with the gliptins, it doesn't with the glitazones, it doesn't. But these drugs do improve your cardiovascular outcomes. And then a really unexpected finding was that they also improve renal outcomes. And so then we went on to do some primary renal outcome trials. So we now have the Credence trial, DAPA-CKD trial, and EMPA-Kidney trial. Credence trial only looked at diabetics with quite advanced CKD, so in this grey category here. DAPA-CKD also looked at patients mostly in the red zone, but very interesting, the EMPA-Kidney trial looked at patients that had kidney function, eGFRs up to 90, and the patients that didn't even have any, had normal ACRs. So it was quite an interesting trial, and it looked at quite a much broader category of patients with CKD. And here is some of the results of some of these trials. So here's the DAPA. This is why we're all using DAPA team. It's the DAPA CKD study. It was a patient, 2/3 of patients with diabetes, and for the first time ever, an SGLT2 was looked at for patients who did not have diabetes. So this was a diabetic drug for the first time being looked at with patients with CKD but without diabetes. And 1/3 of the patients, this was really quite brave of the drug company to do this study, bearing in mind that when you've got CKD, the SGLT2 inhibitors are much less likely to have an effect on your HbA1c. So anyway, the range of patients included had a GFR of 25 to 75. They had an ACR of 22.6, recognize that number, or above. 2/3 had diabetes. 96% had hypertension because they're diabetic and they've got CKD. Of course, they've got hypertension. And 98 were on an ACE or an ARB. The primary endpoint was a composite, and that's a joint endpoint, which we described as if your GFR dropped by 50%, then that's an endpoint. If you reached end-stage kidney disease, that's an endpoint. Or if you died from kidney failure or cardiovascular death, that's an endpoint. So all clubbed together, this is the primary endpoint. So renal endpoints together with death. Secondary endpoints, less interesting. Okay, so let's come to the results of this, the DAPA-CKD study. So this is placebo, but in fact, placebo is standard of care. So these patients were well managed. Their blood pressure, they were all on ACE or ARB, and their blood pressure was well controlled. and then they got added dapagliflozin or Farxiga to the standard of care. And at the end of, so this is 1 year, you can see the curves are separating. 2 years, they're far apart. And by the end of 3 years, there was a 40% reduction in the primary endpoint. So that is your risk of doubling your serum creatinine or halving your eGFR, reaching end-stage kidney failure or dying. A 40% reduction in risk, team. We did not see that. The last time we saw 40% reduction was with a statin post-MI. This is primary prevention. These drugs are really, really powerful. And we need to be, if we're not using them in a patient who has an indication, we need to be thinking, why not? Would you not like your brother, sister, dad, whoever, to have a 40% reduction in their risk of developing death or kidney failure? What about in different subgroups? So if they were older or younger than 65, so this shows favors dapagliflozin and this favors placebo. If the line touches the line of neutrality, then it's not significant, but these show clear significance for all patients up here. Age, sex, race, region, everything, all the subgroups favored. What about some of the patients with and without diabetes? So this is a bit here. So patients with diabetes, we know the drug works, 36% reduction in the relative risk. Patients without diabetes, it works just as well, halving the risk of your
Works better.
well, you know, probably there's no difference, but shit, it's no worse, right? So if you've got CKD, you need to be on an SGLT2 inhibitor. Cardiovascular outcomes, 30% risk reduction. Heart failure, something like 40% risk reduction. Hospitalization for heart failure, something like a 50% reduction. It goes on and on and on and on. And you can see how quickly the curves separate. This is at like 3-4 months. That's your risk of heart failure and cardiovascular death. So for me, one of the most compelling reasons to start a dapagliflozin in elderly patients who you might otherwise be thinking, oh, I'm not so sure, what if they fall over? If you're going to reduce their risk of coming in with cardiovascular death and heart failure, then we should be doing that, really. What about their major? So this is in the DAPA CKD study. There was basically no increased risk of any of the major side effects, but this slide comes with a health warning. These studies are not big enough to pick up major differences in risk, but just for a safety point of view, there was no particular risk of diabetic ketoacidosis, amputation, fracture, volume depletion. AKI was more in the placebo group. It kind of goes on. So these trials are not set up to pick up real safety concerns. That is what I would say. This is important, isn't it? So when we start DAPA, there is a drop in GFR. Sometimes it's more than 4. It can be as much as 6, 7, 8 mils per minute, but it then tends to come up a little bit. But the important thing is to hold your nerve and keep going, because it will over time it will preserve your eGFR. So we expect a little drop. We see exactly the same with the ACE inhibitors, and we hold our nerve and we keep it going, unless of course it drops and it keeps dropping. Then you need to think about something else. What about EMPA? It would be very rude of me not to talk about EMPA if I've just gone on and on and on about DAPA. Right, so the EMPA kidney is the largest dedicated trial in CKD, 6,000 patients as opposed to like 3,000 or 4,000 in DAPA. Placebo and standard of care versus EMPA 10. The median follow-up was 2. The trial was stopped early. Same endpoints, cardiovascular death or kidney disease progression. Patients with or without diabetes, exactly the same patient population, but some lower risk. So 30% were diabetic, 20% were hypertensive, 25% had glomerular excuse me, glomerular disease, the average ACR, and this is not in our numbers, this is American numbers, this equates to an ACR of 30. So established albuminuria, there was about 50%, and lower levels of albuminuria were the other 50%. So same thing. This is their primary endpoint of doubling serum creatinine or halving of eGFR, end-stage kidney disease, death. A 28-30% risk reduction with empagliflozin. Safety profile exactly the same. So what are we going to do from evidence to practice? How long have I got? Let's see, what time is it? I think you've heard most of it actually. So I, with my colleagues, looked with some primary care colleagues in Oxford, looked at what we were doing in primary care and how many patients with a CKD guideline appropriate for an SGLT2, how many were getting them. So according to the South West London guidance, the NICE guidance, the UK Kidney Association guidance, less than 20% were getting an SGLT2 inhibitor with the diabetes and CKD, and less than 1% just with a CKD. But you can see what game changers they are. So why are only 1% of our CKD population without diabetes getting an SGLT2 inhibitor? So we're not doing this well enough. And the reason when we looked into it that people were not getting an SGLT2 inhibitor was because they hadn't had an ACR checked and they weren't on an ACE or an ARB. So here's where we need to start, right? We need to start with ACE or ARB and get their blood pressure to 130/80. We need to maximize the ACE ARB, right? And don't combine them. You don't use ACE and ARB, but I don't think anyone does that anymore. And certainly pharmacists would never do that. It's only stupid nephrologists that might. Anyway, so the TA for DAPA says offer DAPA as an add-on to optimized care in people who have an eGFR of 25 to 75 and who are either diabetic or have an ACR of over 22.6. If they're diabetic, they should probably be on it anyway. So that's that. CKD for empagliflozin, this is the nice TA for that. So if they've got an eGFR of 20 to 45, so this one is 25 to 75, this one's 20 to 45, or they've got an eGFR of 45 to 90 and albuminuria, or they're diabetic. You see, this is where we go wrong as a community in making it one drug for one drug because of their trial. We need to say 20, eGFR over 20, with or without albuminuria, because that's where we're at now, because you can give EMPA if your eGFR is 20 to 45 without albuminuria, right? So we need to be thinking if they've got a GFR 20 to 45, then they need to be on an SGLT2 inhibitor. And they definitely need to be on it if they're diabetic or they've got albuminuria or heart failure. So this is the London Kidney Network. So everywhere across London, the London Kidney Network are pushing out this. We need to reduce variation. So we shouldn't be one GP practice shouldn't be doing it from a different GP practice. One nephrologist shouldn't be doing it different from another nephrologist. Everyone should be doing the same, and we should all be looking to screen our population to identify CKD. And anyone with type 2 diabetes, CKD and albuminuria, they need to have optimized standard of care, which is ACE/ARB, blood pressure management, lipid management, and an SGLT2 inhibitor. Easy. And we need to be thinking anyone with an ACR over 25, anyone that's diabetic, and anyone that's heart failure, and definitely if you have all of the three indications for an SGLT2 inhibitor. Action 1. Maximize the intensity of the RASI. And I don't agree with this. I wasn't on the guideline writing committee. I would have said get them on a RASI, and it really doesn't matter if it's losartan, the shortest acting, most benign, ARB, 25 milligrams. Put them on it, then get them onto an SGLT2, and then you can play around with it as much as you like, optimizing it. But don't optimize it, then get hyperkalemia and stop it. And then they never get anywhere near an SGLT2 inhibitor. So I would say action 1, get them on a RASI blocker and get them on a statin. Month 2, as soon as they're on a RASI, start them on an SGLT2 inhibitor. And then fiddle around with your blood pressure and your dose titration and everything else. And I'm going to finish there by saying I've already said to you who you should be referring. So anyone with refer adults with CKD if they wish it, if they've got a 5-year risk, or if they're on the red marker of the CKD coding. If they've got a rapidly progressive fall in EGFR, and I would say EGFR of 20 to 25, or a sustained reduction of 10 to 15 per year. If they've got proteinuria or albuminuria. Okay. So we have opportunities, we have the tools, we just need to use them, and we need to use them more. We need to screen our populations for CKD, and then we need to code them. And as soon as they're coded, we need to tell them that they've got CKD, we need to give them information on CKD, and then we need to use the 3 steps that the London Kidney Network say, which is ACE-ARB, SGLT2 inhibitor, statin, and then blood pressure control. Okay? Easy job. Easy job. We're very, very capable of it, but we need to get on and do it.
Amazing. Thank you so much, Pauline. That's been really, really helpful. I have had a few questions that have been sent to me, which people aren't putting in the chat for some reason, but they're sending them to me, which is fine. And I will answer them as I always do. So I've got a question here, for example, saying, I've got one in the chat. We'll do that one first. So it says, if creatinine clearance is above 20 ml per minute, can EMPA still be used?
Yes. Yes.
Irrespective. So irrespective of EGFR.
Yeah, you can initiate it GFR. You can initiate it at 20, and you don't have to stop it if it falls below 20.
Exactly.
Until they reach dialysis.
Yeah, leave it. Start it. Keep it. Leave 10. It.
Yeah.
That's my planning. Start it. Keep it. Leave it. If we've got another one, so if we've got, for example, we're going a lot with UACRs. If we've got nursing home patients, for example, or very frail patients who can't do the UACR, do we just simply code them as CKD 3, 4, whatever they're coming up through?
G3, G4, yes, but it would be better.
You can't add in the A part.
I don't know what you do about that. I don't know what you do about that.
I think we just probably need to I was looking at the system, I think you just need to code them as G3. And I think that's going to be where you can just go and stay. You can't add in that. So you're going to have to just go with what the best you have.
Yeah.
There isn't a way of exemption reporting it, unfortunately.
No. Okay. As long as that doesn't stop them being on their ACE, but they, if they're diabetic, that's fine. You can start
still put them on SGLT2. Absolutely.
If they've got heart failure, you can still start them on. But actually now, so there was a question, the last question was if your ACR is like 20 and it doesn't reach the threshold of 22.6. I would start it. I do start it, but now you can start EMPA anyway. So you
Absolutely.
Can start EMPA if you don't have a raised ACR.
As long as the EGFR is between 20 and 45. Yes.
But I would still start it. If it was 46, I would still start it. If it was 50, I would still start it.
Yeah, I think that's where I think as pharmacists we'd send in advice and guidance. Pauline, do you mind us starting it? And you'll say yes, and we crack on, and that's the way we would do it.
Yeah, if you want to do it that way, definitely make it my fault. More than happy for you to put that in an A&P.
I think if you've got a specialist backing it, it makes it easier. And I know that's something I've done with yourself. I've done it with Gareth as well. Yeah. Makes it a little bit easier on that front.
Yeah.
So it says another question that I've had come through is when replacing historic code, should we backdate it when coding an ACR if available? I'd say backdate it if you can. Get a fresh ACR, code it what you've got now. That's going to be the easiest option, and you've got it up to date that way, rather than trying to backdate something. To be honest, if you've got someone who's got a positive ACR, I'd rather we go and repeat that, know where that risk is now, rather than sticking to what the risk was a year, 2 years ago.
Oh, I agree with that, but you should still code it for the ACR that you've got, and then
Yes,
update your code.
and update it.
If
Absolutely.
they've got a positive ACR, they've got a positive ACR. And it
Absolutely.
varies, you know, so sometimes it's going to be 10 and other times it's going to be 30.
Absolutely.
You know, these are all guesstimations. So the KDIGO, which is the global kidney,
The KidGo is what I call it. Yeah.
KDIGO, yeah. They were almost thinking about saying, oh, screw this, you know, why do we have to do everything within, you know, get one level and then recheck it in 3 months, whatever. If you've got an abnormal EGFR, you've got an abnormal
EGFR.
Yeah, absolutely. And we should just go with that. And the same, I think, is true with the ACR. So let's not be too purist, because our numbers are not that great at the minute. We need to get on and code. So use what we've got. Ideally, think kidney health check. If I'm doing an EGFR, do I need an ACR as well?
Absolutely. There is obviously other things coming in, like finerenone, which are in the background, which we're not going to talk about today. They're coming through, but they're not there yet because those are still hospital specialist only. But watch this space. There are new things coming out for kidneys. And to be honest, I think they're probably going to be pushed out towards primary care long term.
Well, let me tell you something, that there is, in the next month or so, the FLOW trial will be published. So that is with the GLP-1 agonist semaglutide for people with diabetic kidney disease, and this is going to be it's been stopped early.
Game changer, from what I've heard.
It's been stopped early because of reduced renal endpoints, and you know, this is what we're seeing in our clinics. We're seeing people with cardiorenal metabolic disease, and they need to be on SGLT2 inhibitors first with their ACE and their ARB and their statin. But if they're overweight, they're going to need to be on a GLP-1 agonist.
Absolutely. And I think that's the best way. If they're overweight, it's not just looking simply at just the kidneys, it's looking at the whole patient holistically and covering everything across the board. And it's not just the idea of a particular morbidity in silo has gone out the window. Comorbidities are real and they are there.
Yeah, absolutely. So
perfect. I think that's all my questions through email. I'm checking my phones in case I've got them. Komal, I'm coming to you in a second. 1 second. I'm just going to make sure I've covered all my questions before I go anywhere. I haven't got any in the chat. I haven't got any on my phone, and I think I've covered them. Komal, my love, all yours.
Thank you, Pauline. I just had two things that I needed to mention. It's really important that when dapagliflozin is prescribed, you do write the indication on, because the glucose lowering effect is reduced below 45. For both, actually, for EMPA and DAPA. So you don't want it to be stopped for patients that are diabetic, or if they've just got CKD. And do not stop dapagliflozin and empagliflozin once you've initiated it, even if the renal function does drop below 25 or 20. Continue it, and then let the nephrologist stop it when they get
to their
do
their thing.
Yes,
Kamal,
so
you're absolutely right, and you know, I was aware that the talk was already really packed full, but you should be writing the indication, but you then should also document that you've had the discussion with the patient, and the MHRA are really saying actually you need to mention diabetic ketoacidosis, or just they've taken diabetic ketoacidosis out of it because the odd patient, very, very odd patient, will get ketoacidosis without being diabetic, just having CKD, but we really don't see that. But you still have to document ketoacidosis and Fournier gangrene. So we say, you know, are you incontinent of urine? If you're incontinent of urine and sitting in wet, sticky, disgusting urine, then I think, oh, I'm not sure I really want to prescribe this. But then I say, keep your undercarriage clean, prescribe it. If it gets really painful or there's a problem, alert somebody, stop it and alert somebody. So you do have to document those two things that you've discussed, even if you discuss it very briefly like I do.
Absolutely. And I think the other thing that you probably want to add into that as well is giving them the sick day rules, because you need to make sure that they know when to stop that medication should those actual issues or problems occur in itself. So I've got a nice little leaflet. I've got a couple of page leaflet, patient-friendly leaflet I've written, which actually I give to all my patients, which I can share if you want. You're more than welcome to have it if you want it.
That would be great, Shandy.
But I think that ties up.
Well, I'm very grateful to you for asking me to come and talk with you.
Thank you so much for coming in and talking for us, honestly, because I think it's been really insightful for all of us. And actually, it's
always nice around on advice and guidance as well. Okay.
Absolutely. Thank you so much, Pauline.
Take care. Bye.
Take care. Bye-bye. So with that in mind, I had it on earlier. I'm going to put it on again. She says, if you haven't already, join our mentee. Give us a bit of feedback about how your talk was and how it went through. So if you haven't already, you can scan this lovely QR code that's over here. You can join on mentee.com, enter your code 5926661, and then give us a bit of feedback and tell us what's going on that front. And it's your way to be able to go and actually give back a bit of information to us on that front. So if you haven't already, giving us some love, thank you for the love. Send us some more love. We like a bit of love. Feel free just to jump on. If you've got your phones handy, scan it across there. And it's just so we can get a bit of feedback and get a bit more of what do you guys want going forward in the next 6 odd months of sessions. We've got some ideas of what we've heard back from our last lot of talks itself and our TNA that we sent out. But this is going to be a way of us trying to go and actually get that information out to you and get you guys involved, hopefully, as well on that front. So the idea would be is if you can go and scan this lovely barcode, makes my life easier on that front. So our first question on that front is, that when we're going and having a look, and I've got a lovely nurse in the background, please ignore her. I'm going to go and just say on that front, who you are, where you're from. So I'm going to turn on responding, she says. What boroughs are you guys from? And I like to go and put my little timer on so that we know we get a good balance on that front of who's on there on that front. So we want to be making sure we're getting a nice spread of people from across the board, she says. So the idea is that we try and find out who you are, where you're from on that front. And she goes and says, I'm going to add in a bit more of a timer so we've got a bit more time. We like our responses, and there's about 40 of you on this chat, so we want to be getting some more people coming through thick and fast on that front. Nice to see Sutton is on there on that front. We've got a bit of representation from Kingston and Richmond on that front, which is great as well. So get more people in. Sutton are killing it today on that front. But we want to be going and getting in because we want to be trying to make sure we're covering all bases. So if you haven't already, jump onto our mentee. Go and get onto our mentee and you can go and follow this through and give us some advice and see how you do. Anything you want to add, Hala, while I'm rambling away?
No, I think Sutton is in majority today, so good to see you guys. It's important for you to stay on the mentee. Please don't log out, only because the next 6 months topics, the direction of the forum is going to depend on your answers on the mentee. So
Absolutely.
Please stay around and just help us to exactly tailor the forum to your needs rather than
I'm giving it the last 10 seconds just so people can just jump on and add in where they're from and who they are and where they're from. Otherwise, basically, we're going to be doing what Sutton wants on that front. So the next question is how did you guys find the session on CKD? Was it enough? Did you need more? Was it just right? Was it a bit too much? How did you find it? That's the key thing for me. And if you can't use the mentee, please put in the chat for definite what you actually found on that.